Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is palliative care for adults and children with HIV, and the speaker is Dr. Rajeeb Day. Dr. Rajeeb Day, sir, is the Technical Specialist Public Health with iTech India. We welcome you, sir, for today's session and request you to start the session.
Thank you, Swetaji. So today's session is on palliative care for adults and children living with HIV from the chapter number 5.7 of National Guideline for HIV Care and Treatment 2021. And this topic was taken by two facilitators as a part of National Distance Learning Seminar Series. And basically today's discussion would be a recapitulation of that. Just a minute. Now, palliative care for adults and children living with HIV. This would be taken care of in the following section, like management of pain, end of life care, palliative care in children, and home-based care. Now, let us first investigate what is the definition of palliative care. It is the care of patient whose disease is not responding to curative treatment. And palliative care is basically an approach to improve the quality of life of patient and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and assessment, treatment of pain and other problems, physical, psychosocial, and spiritual. And this palliative care not only provide up to the patient level, it extends beyond that up to the family during the process of bereavement. Now, if you look at the continuum of care in HIV, you will find that if you follow my cursor on the diagnosis, both the things starts. Initially, the green one, this part, is the curative care. We have lots of options to treat the patient adequately, and the palliative care is very little. But as the disease progresses, gradually we find the scope of palliative care increases, while that of curative care goes on decreasing. And at death, the highest amount of palliative care needs to be taken, and while there is very little regarding curative care. And even after that, the process continues for the counseling of bereavement for the people, for the families and the caregiver. Now, so this palliative care is basically family and patient-oriented, patient-centered, and it optimizes the quality of life by active participation and prevention of sufferings and treatments of suffering. It also involves a multidisciplinary team throughout the continuum of illness, placing critical importance on building of respectful and trustful relationship. And we should address the physical, intellectual, emotional, social, and spiritual need of that particular patient and its caregivers. Now, there are different components of palliative care. These are basically centered around pain management and control of suffering and prevention of suffering. Then management, symptomatic management need to be done because we don't have any curative treatment. So during that time, we should provide symptomatic management of different complaints. It can be psychological, it can be economical, it can be religious. So we need to provide a relief to the patient. Then nutritional support, and this is most important in the those patients who are having, say, malignancies, and also in the CLHIV, this nutritional support becomes very, very important. Then psychosocial support, because the patient in palliative care, they already know, the adult people already know that they're going to die, nothing is working in them. And so they suffer from lots of psychosocial issues, like what will happen to their kids after their death, what about the economical security, and who will take care of their children. All those things are there, and we need to provide support to those people. Then spiritual support also. The patient may have some guilt and all, and during that phase of palliation, the patient frequently goes through all those psychological thing of their life, and end of care, and then bereavement counseling. These are the components of palliative care. Now, management of pain is the central part in the palliative care, so far as the patient is concerned. Now, first we'll have to assess the patient for pain. That is, we need to know the severity of the pain, site of the pain, and nature of the pain. If there is any infection leading to this pain, we need to control the infection with proper anti-infective agent. And the severity of pain can be graded by different methods. So, PQRST characteristics of pain need to be assessed during the assessment of pain. That is, P stands for palliative factors. That is what makes it better. And it also stands for provocative factor. That is the factors that makes it worse. And Q means quality. That is what exactly it is. Is it a pinching pain? It is a dull pain, aching pain, etc. So based on the quality of the pain, we can guess towards the diagnosis and possible intervention that will reduce the pain. And then radiation. Does it spread anywhere? Now, in radiating pain, we all know that antiepileptic drugs and amitriptyline, all this works quite nice. So we also need to know whether it is radiating in nature or not. And the severity, how severe it is. How much does it affect your life? Or the temporal factors, that is there any time of day it becomes more severe, or it comes or it goes? And is it worse at any particular time of the day? Or it is a bit better during any time in the day or at night. Usually these pains tend to be more severe at night whenever the patient is lonely. And there are different scales for the measurement of this pain. And these pains can be descriptive scale, numeric scale, visual analog scale, percentage scale, point scale, phase scale. And out of these different possible, different available scales, the most useful is probably this pain or emotion scale, which can be used for the layman and which also can be used by the educated people. So here you can see 0 means no heart. You can see the facial expression. We know how does it feel whenever we are going through different stages of pain. So we can readily read it from the face of the patient. And the patient can also confirm by point. Swetaji, is my screen visible?
No, sir. No, sir. You'll have to reshare, sir.
Okay.
Yes, sir. Now it is visible.
So we're discussing the route of pain medications that the preferred mode is basically oral or rectal, but we tend to avoid the intramuscular route because it itself can give rise to pain, additional pain. And it is hygiene also need to be maintained if we are going for any invasive method. So best is the oral administration followed by rectal administration. And it should be given by the clock. That is after assessment of the pain, if depending on the half-life of a particular agent that we're using, we should be giving it as a fixed time, say twice a day or thrice a day or 4 times a day. And the next dose should be given before the effect of the previous dose wears off. Means if we are going for, say, paracetamol, we know 650 milligram of paracetamol is effective every 8 hours. But if we can give, say, 500 milligram of paracetamol every 6 hours, then before waning of the effect of the previous dose, the new dose will start acting. So there will be pain relief to the patient. So those things we need to keep it in mind while treating a patient, a patient in palliation suffering from severe pain. Now, what are the different agents that we can use to control pain? Depending on the severity of the pain, we can give one drug from the opioid or one drug from the non-opioid group, but preferably we should start from the non-opioid group if the pain is a milder one. Then pharmacotherapy must be individualized to maximize pain relief and minimize adverse effect. As I was discussing that in case of paracetamol, 650 milligram thrice a day will suffice, but it is better to give say 500 milligram 4 times a day, so that before waning the effect of the previous dose, the next dose will start. Next action of the next dose will start, and the patient will have a sustained pain relief. Now, WHO three-step pain relief analgesic ladder, that is, in case of mild pain, we should go for aspirin or paracetamol or other NSAIDs, non-steroidal anti-inflammatory disease, and plus minus adjuvant. There are different types of adjuvant that we'll go through in the subsequent slides. And if the pain is moderate, then we can go for codeine, hydrocodone, oxycodone, dihydrocodone, or other adjuvants. And if the pain is very severe, then we go for morphine, hydromorphine, methadone, then levofranol, then fentanyl, oxycodone, and other adjuvants with or without other adjuvants. And we should try to give all those things by mouth wherever possible, or at times through the rectal route. So in the step one, we go for non-opioid plus minus adjuvant. If the pain increases despite of non-opioid, that is NSAID and adjuvant, then we go for weak opioid for mild to moderate pain, with or without other non-opioid plus minus adjuvant. Now, if the patient is severe, then we go for strong opioid for moderate to severe pain. And if there is pain, freedom from pain, then we continue that. And if not, then we can use other non-opioid killing painkillers like NSAIDs, with or without other adjuvants. So these are the different pain-killing agents like acetaminophen, aspirin, ibuprofen. We know the doses. Here we need to notice that aspirin, for cardiac purpose, we give very low dose of aspirin, but for management of pain, that dose is quite high, around 650 milligram for hourly. So these things we need not memorize. We need to keep this table, this chart or table, and we need to consult these doses whenever required. Again, these are the different doses of different molecules. So let us discuss a little bit of opioid for cancer pain. Morphine sulfate immediate release is given 30 milligram 3 to 4 hourly per oral. Morphine sulfate control release 10 milligram 3 to 4 hourly IV. Morphine sulfate sustained release 30 milligram 12 hourly per oral. Morphine sulfate suppository can be given as per the need. And oxycodone hydrochloride immediate release 10 milligram 4 hourly per oral. And oxycodone hydrochloride 20 milligram 12 hourly per oral. Hydromorphone 6 milligram 12 hourly per oral, and fentanyl 50 milligram per hour, or for every 72 hours. Then fentanyl sublimise, that is 50 milligram via continuous infusion can be given. Methadone hydrochloride 20 milligram 6 to 8 hours per oral, and levorphenol tetrate 4 milligram 6 to 8 hours per oral can also be given to for the management of pain. Now we know this NSAID, that is the non-opioid, non-steroidal anti-inflammatory drugs, they affect through the different pathways than the opioid. They use the cyclooxygenase pathway. There are two types of cyclooxygenase pathway we all know, that is COX-1 and COX-2. Ketorolac is available as oral, intramuscular, and IV formulation. The choice of NSAID must be individualized to patient's needs, and NSAIDs are basically GI toxicity, ulceration, and bleeding, and we should take care of proper prophylactic measures. We need to take proper prophylactic measures so that the patient doesn't develop ulceration, bleeding, or flatulence. And since these NSAIDs and opioids have different mechanism of action, so logically we can use both of them, and we'll have an additive effect in alleviating pain. These opioids are the essential component of pharmacotherapy of pain and can be classified as weak or strong depending on their relative efficacy and releasing pain. Morphine sulfate is the prototype opioid against agonist and is designated by WHO as drug of choice for treatment of severe pain associated with cancer. The half-life of morphine is approximately 2 hours, and it is available both as an oral immediate release preparation and slow release preparation that permit once or twice daily drug regimen. Oral administration of opioid is convenient and is well tolerated, inexpensive, and effective therapy. However, there can be some side effects in the form of constipation, nausea, and vomiting, and we can also take care of these possible side effects. That we were talking about the adjuvants. So these adjuvants can be in the form of non-pharmacological therapies like quick distractions in imagery. We can divert the patient's mind. And then hypnosis can also be used, music therapy, specialized cognitive behavioral therapy, and we can minimize the pain. And there are different counselors who are quite expert in this hypnosis and cognitive behavioral interventions for the management of pain. And then massage therapy can also be used. Thermal modalities, other like cold water or warm water, can also be used. Then electric stimulation can also be used. All this act as a basically diversion and also produces local soothing effect. And medications for special pain disorders, like for burning pains, abnormal sensation pains, severe shooting pains, we can go for pregabalin, 75 milligram twice a day, or low dose amitriptyline, that is 25 milligram at night. And we can wait for 2 weeks for response. If there is no response, then we can gradually increase the dose to 50 milligram at night or 25 milligram twice daily. And this amitriptyline is quite good in alleviating both radiating pain and also the anxiety and depression in that particular patient. And pregabalin is also capable of treating a little bit of anxiety along with this pain. So these are quite useful medication for pain management during palliation. And for muscle spasm in end-of-life care or paralyzed patient, we can use diazepam, 50 milligram orally or rectally 2 to 3 times a day. Now, herpes zoster for shooting pain, we can easily go for acyclovir along with amitriptyline. And gentian violet if the vesicles of the herpes zoster ruptures. Now, for gastrointestinal pain, for colicky pain, we can go for codeine 30 milligram every 4 hours or hyoscine 10 milligram 3 times daily. For colicky, so for example, the pain from the, say, renal stone or gallbladder stone, we can go for hyoscine also. It is quite useful in those type of pain. And bone pain or renal colic or dysmenorrhea also can be effectively treated with ibuprofen. Now, spatial plane problems, if there is any swelling around a tumor, or if there is severe esophageal ulceration and patient cannot swallow, or there is nerve or spinal cord compression, and if there is persistent severe headache due to a rise in intracranial pressure, we can go for steroids under careful clinical supervision. The other methods are emotional support. Many a times when the patient becomes lonely, they feel more of pain. So giving support to them and talking to them, and with say physical touch, either massaging a part or stroking or simply vibrating an area, affected area, or by simple touch, the pain gets reduced. And we can also use ice or heat, and deep breathing is also a relaxation techniques, which can be taught to the patient if the patient is capable of doing so. And other cognitive methods like distractions into listening to music, radio, and other imaging a pleasant scene. Suppose the patient had a very good experience and memory of a previous event, then the patient, we may guide the patient to close the eye and to imagine those events whereby the pain perception gets reduced and the patient becomes a bit better. Now, with respect to patients' religious beliefs, prayer is also very useful in reducing the pain. Then symptomatic management. If the patient is having nausea and vomiting, we can give antiemetic, ondansetron. It is very good for nausea and vomiting during the palliation, particularly if it is due to cancer chemotherapeutics. And it can be given for a day at a time, like 3 times up to 20 milligram thrice a day, or we can also use metoclopramide 10 milligram TDS. And we can also use haloperidol. 25 to 50 milligram every 6 to 12 hours. And injectable antiemetics may be needed in severe cases where the patient cannot tolerate oral tablets. And other home-based care can also alleviate nausea and vomiting. And we should advise them to eat small quantities of meal and frequent meals. Avoid empty stomach, because if we take this NSAID and other pain medications in empty stomach, it makes the abdominal pain and nausea, vomiting worse. So we advise them not to keep the stomach empty. And we should also advise them to eat bland food, and and to avoid food with strong or unpleasant odor, drink plenty of liquids, and relax in between meals and after meals, and avoid lying down immediately after eating. Avoid coffee and alcohol, and we should assess for any signs of dehydration and consult the healthcare provider if there is a dehydration. Now see, this palliative care, home-based care, basically the patient at home. So we need to teach their caregiver or maybe an ASHA who is catering to that particular patient of that region, that to assess for how to assess for dehydration, and if there is any dehydration despite of their home-based care, if it is not going, then the patient need to consult a healthcare provider, and we need to train those caregiver at home or the ASA when and where to send the patient if such kind of complications arises. In case of painful mouth ulcers, if it is candida, we can give fluconazole or nystatin or miconazole orally. Topical anesthetic can provide some relief. Pain medication may be required according to analgesic letter that we have investigated in an earlier slide. Then for aphthous ulcer, we can crush 5 milligram of prednisolone tablet and apply a few grains over the ulcers, and it will heal in quite easily. Smelly mouth or halitosis, for oral cancer and other lesions, we can use metronidazole, 400 milligram BID, or chlorhexidine gluconate 1%, 10 ml 4 times a day for washing mouth, or hexidine 1.1%, 10 ml PQRST, or for washing the mouth. Now for herpes simplex, we can use 3 ml nystatin solution, 2 tablets of metronidazole, and 1 capsule of acyclovir, and other pain medication if required. Now, home-based care for all this and pain on swallowing, we can use remove bits of food stuck in the mouth with cotton wool, gauze, or soft cloth, and soaked in salt water. We can advise the patient to rinse mouth with diluted salt water, a finger pinch of salt, or a half TSF of sodium bicarbonate in a glass of water after eating and at bedtime. And we can mix 2 tablets of aspirin in water and rinse the mouth up to 4 times a day for alleviating the painful mouth ulcers. And soft diet to decrease discomfort, such as rice or porridge, or depending on whatever is available locally, we can use soft diet. And more textured food and fluids may be swallowed more easily than fluids. And we should avoid extreme hot or cold or spicy food to prevent these painful mouth ulcers or difficulty in swallowing. Commonly administered anti-emetics classes, drugs, and dosage schedule. So serotonin receptor antagonists like ondansetron, granisetron, etc. we can use. We need not remember that. We can keep this chart in our clinics so that we can consult whenever required. So just to enumerate, phenothiazine like prochlorperazine is a very good antiemetics, and butyrophenone, corticosteroid, cannabinoid, and benzodiazepines can also be used. Now, handling of PLHIV with hiccups. This hiccups is quite common in the palliative care, and it can be due to vagal nerve stimulation. It can be due to irritation to the diaphragm. It can be due to renal failure, or it can be due to some brain tumor. So we can try these maneuvers, like first try to take care of the oral thrush or the esophageal candidiasis, if any. If no response or recurrent, then we can go for metoclopramide 10 milligram TDS, or even 4 times a day. And if the patient is not responding, then we can go for haloperidol 5 milligram, or half tablet 1 to 3 times a day. And if the patient is having brain tumor, then we should go for antipyretic medication like sodium valproate or phenytoin. And the maneuvers that can be used to prevent hiccups or to control hiccups are the stimulate the throat. By stimulating the throat, we'll be stimulating the vagal nerve, and it may take care of the hiccups. And we can ask the patient to eat 2 tsfs of sugar quickly, or drink cold water, or eat crushed ice, or rub it with a clean cloth inside the top of the mouth. Or we can interrupt the normal breathing by holding breath or breathe into paper bag. And we can also advise the patient to pull the knees to chest and lean forward, which compresses the chest, and many times it also controls the hiccup. Now, for bedsore, all patients need skin care to avoid pressure problems, and this should start right from the very beginning right from the beginning. If the patient is not mobile, then immediately we should start this and check for signs of infection. And for smelly tumors or ulcers, we can sprinkle metronidazole powder to cover the area and keep the area dry. For small sores, gentle wash with salt water and allowing them to dry may suffice. And we can apply honey to bedsores that are not deep and leave the wound open to the air. If painful, we can go for painkillers such as paracetamol or aspirin regularly. For deep or large sore, every day we need to clean gently with diluted salt water, fill the bedsore area with pure honey, and cover it with a clean, light dressing to encourage healing. But change of posture is very, very important to prevent the bedsore, say every half an hour to 1 hour. If we can change the position of the patient on bed, then it will prevent the pressure sores. Or we can use also other air mattress or water mattress in those cases who are impending to develop bed sores. Now coming to end of life care. How people die lives in the memory of those left behind. That is, the person who has to die, say suppose he dies, but his family members, caregiver who are left behind, they will remember that incident. So if the patient can die with dignity, with proper care, then this gives a good feeling to the person who are left behind. It is very difficult to predict when the patient is going to die. So it is better to practice this thing right from the very beginning. And the aim of care that we should not try to predict when the patient is going to die. We should try to comfort the patient as much as possible. And we need to focus on reducing the suffering of the patient as much as possible, and to prevent if possible, or to limit the suffering as much as possible. And other patients, active listening, counseling, and social or emotional support is very, very important. Spiritual support is also very important, and it is based on the belief system of the patient. And we can go for some people may go for gurus, and some people may go for the priest or the clerics of a mosque or a church. Then learn to listen with empathy. It is very, very important that we should respect the patient. We should listen carefully, reflectively to the dying patient, and also to those those of the caregiver. All their concern needs to be addressed in a proper way. And we should also understand the reaction to their losses in their life, and anybody who is providing this end of care services need to be prepared to absorb some reaction. That is, the patient or the family member may have anger projected onto the healthcare provider for the impending death of the person. So we need to be prepared to absorb them in a graceful way, and we still need to maintain the empathy and to provide them the best possible social, emotional, and psychological support. And while providing this, we should not be imposing our own views. We should share religious belief with the appropriate person as required. And we need to empower the family to provide care, because this hospice care or the palliative care can be done in institution based, or it can be done at home. And home based one is probably better in Indian context. And for that matter, we need to train the family members how to share the concern of the dying patient, and how to take care of the patient, how to keep him hygienic, clean, and deal with their anxieties and fears gently. That means the survivors, that is the caregivers who are going to survive even after the death of the patient, they may have many anxieties and queries how the who will take care of the custody child, etc. So we need to address them in a proper, so that the caregivers can have their own decisions. Now, preparing for that, encourage communication with family, because many a times these people have different kind of emotional thing associated with other family members. So it is very important freely with their family and discuss worrying issues such as custody of the children, family support, future school fees, old quarrels, funeral costs, etc. That they can discuss with the dying patient, and tell the patient that she is loved and will be remembered. So that gives solace to the patient. And talk about death if the patient wishes. If the patient is not wishing, then we should not force on talking about the death. And help with feeling of guilt or regret that I was saying earlier, that many a patient in these terminal stages, they usually face some guilt or regret for their some past deeds, and we need to counsel them in an educated way, and we need to try to normalize all those emotional sufferings by relating to some other previous patient, or to or by some storytelling, and connect with the spiritual counselor or pastoral care can be advised if the patient believes in it and the patient wants it. Now, the patient need to be approached with compassion, and outreach visit regularly has to be done by the outreach worker at the home whenever the patient is in home-based care. And the touch is very, very important in the terminal stage. So we need to train the caregivers and the outreach worker to touch the patient, shake the patient, and then so that he feels better. And then comfort measures near the end of life. Then for say, we can use moisturizer in the lips, mouth, eyes, keep clean and dry, and prepare for incontinence of bowel and bladder, which are quite common towards the end, and only give essential medications. That is, we should not complicate by giving unwanted medicines and producing lots of side effects. So we should be very judicious, even if when the patient is dying, regarding the choice of medicine, amount of dose of medicine, and the frequency of medicine. Now, control symptom with medical treatment as needed to relieve sufferings, including antibiotic, antifungal, as we were discussing. In case of odynophagia of say esophageal candidiasis, we need to use antifungal in a timely manner. And if the pain is due to any infections, then we need to use anti-infectives in the form of antifungal or antibiotic or antiviral. Eating less is okay, but we need to ensure that the hydration is adequate. And skin care, for as we were saying, that every 2 hours or more frequently, we need to change the position of the patient on the bed to prevent bad sore. And the pain is the central part in palliative care, and we need to ensure that pain is controlled as much as possible without producing much side effect. Signs of imminent death. Decreased the signs are the decreased social interaction. The patient will tend to sleep more, act confused, and maybe comatose. And there is decreased food and fluid intake. The patient may not feel any hunger or thirst. Changes in elimination, that is reduced urine or bowel movements, or there can be incontinence. And respiratory changes can be irregular breathing or and circulatory changes, cold and grayish or purple extremities, decreased heart rate and blood pressure. And signs of death, we all know: breathing stops completely, heartbeat and pulse stop, totally unresponsive to the shaking or shouting, eyes fixed in one direction, pupils dilated, corneal reflex is not there, eyelids open or closed, and changes in skin tone, white to gray. Now, and this is the palliative care. Up till this, we were discussing the palliative care in adults, but in children also, many a times we tend to ignore that the patient may not, the child, CLHIV may not feel pain, and it is many a times it is seen that pain in children is many a time ignored. And this palliative care in children is becoming more and more relevant and important and challenging because of the successful antiretroviral therapy. The children of today's who are having HIV are living longer, and as such, they are also suffering. They are also facing lots of sufferings, both physical, mental, social, and emotional. And we need to take care of them also. And this whole new chapter of palliative care in children is also very relevant. So we need to know a little the finer aspect, the finer differences in adult and children. The most important thing is that this childhood is basically a phase of rapid growth and development, both in psychologically, physically, mentally, emotionally, everywhere. So palliative care for a 3-year-old child may be different than that of 7-year-old child. So we need to take care take into consideration the growth of the patient, both psychological and physical growth, to tailor the palliative care to the particular CLHIV. So it is similar to the adult one, the comprehensive care for children living with life-threatening and life-limiting illnesses. So it is the active total care of child's body, mind, and spirit, and involves giving support to the family. It begins when illness is diagnosed and continues regardless of whether a child receives treatment directed at the disease. Health providers must evaluate and alleviate a child's physical, psychological, and social distress. And effective palliative care requires a broad multidisciplinary approach that includes the family members, and make use of available community resources. It can be religious gurus, or it can be a psychologist for addressing different psychological sufferings. And integrated palliative care consists of outpatient, inpatient, hospice care, and home care to maintain continuum of services. The important things in child care, child palliative care is basically mutual trust. We should not ignore them only because they are young, or they are, say, some people may not depend on rapport establishment and trust development, but we need to do that just like an adult individual. And child development needs to be taken into consideration. And care at home, most children are cared for at home. If the parents are still alive, they usually take care of the patient. If they are capable of, if they themselves are very sick, then maybe some other family member should be trained to take care of the child. And we need to train them both in terms of skills and empathy and all, and how to listen to the child in an empathic way. And assessing symptom in children is the CLHIV home may develop some signs and symptoms where the consultation with the healthcare provider is needed, and we need to train those at home who are in charge of the patient and providing the palliative care to recognize whenever there are some symptoms, and when to consult the healthcare worker, where and how. All these things need to be trained, need to be told the caregivers beforehand. Now, palliative care team should provide support during emergencies and healthcare crises, and help in the challenges of day-to-day living. Symptoms and pain management, as we are discussing, it can be home-based care also, or it can be some medications, in which case the patient need to consult the healthcare worker, or the palliative care team member who is going for outreach of the patient might provide those medicine in consultation with the treating physician. And we should also provide prophylaxis to the patient. So suppose the patient qualifies for quatrimoxazole prophylaxis therapy based on the CD4 count, then we need to provide them with the CPT. So the essential components of palliative care for children are Basically, pain management is the central one. Then symptom management is psychological, social, emotional, whatever symptoms are there. We need to listen to them and we need to elevate the sufferings. And here, the storytelling and drawing can also be used to express their feeling, because this younger child, they lack proper vocabulary to express, and they also might fear at times what the people will think, and they may not express it. So by saying storytelling or by drawing, the children can easily express their emotions. And we should also, based on their emotional sufferings, we should also provide psychosocial and spiritual support in the form of, say, counseling, or in the form of minimizing their, normalizing the situation by storytelling and all. Now, reasons for inadequate treatment of pain in children, that they are unable to express their pain due to their age and lack of verbal skill or disability. Few healthcare professionals are trained and skilled at evaluating children's pain and suffering. So majority of health professionals also lack the competence in prescribing opioid in children, because many a times treating physician may think that it will give rise to addiction, dependency and all. But a person who is dying, who doesn't have much time left, then this addiction part is probably not worth considering. We should go for adequate doses of opioid in children as per the age and weight criteria. And we should try to limit the side effects. Say, for example, constipation, nausea, and vomiting. Now, fear of using opioids for pain management due to common belief that it will lead to addiction. So this, we should not consider it. It is not a factual thing for a patient who is in severe pain, agonizing pain, and who is going to die, who is not going to survive for a long time. Now, acknowledgement and support of spiritual issues and pain and conflict, and the impact of culture and language is mostly ignored in children. So we need to focus on those areas, the spiritual belief of the children. How do they, what are the conflict between, if there is any conflict between the parents or between the child and the parent. So we need to take care of all these things, and we need to ease the situation for the children and also for the for their caregivers. Many times this patient, this CLHIV may have a anger against their parents. He or she may think that they willfully infected him and all. So all those proper way. Now, non-pharmacological measures in cases of CLHIV in palliative care are the age-appropriate destructive active distractions, then concentration on a game or conversation or spatial story which the CLHIV like, or caring an infant, providing warmth, breastfeeding or feeding, rocking or stroking or massaging. All these are important for the CLHIV who is under palliation, just like adult human being who need touch and comforts. Then relaxation techniques and behavioral modifications can also be attempted wherever available. And environmental management, like play opportunities are to be included, the music, the scheduled medical and nursing interventions, and structure opportunities for sleep and rest. And nutritional support is very, very important for young CLHIV, and adequate hydration and electrolyte maintenance balance is also important to look for and to ensure that. And symptomatic managements of HIV is associated with a variety of symptoms due to infection itself, opportunistic infection, and treatment side effect. Common symptoms include fever, cough, diarrhea, anorexia, sore mouth, nausea, vomiting, and shortness of breath. These are major cause of discomfort and poor quality of life during HIV infection in infants and children. Many of these symptoms can be prevented, treated, or controlled with basic medications and therapies that we discussed earlier, or with some home-based remedies also can be used. Non-pharmacological methods are important adjuvants to symptomatic management, and these alleviate symptoms so that the patient function freely, and we should not freely without any restrictions as much as possible. Psychosocial and spiritual support, and here it is very, very important to changing family dynamics because the caregivers, in most of the cases, may be parents, but many of the parents may themselves are undergoing palliation. They may not be capable of taking care of, and so the caregiver changes in the family. And with the change in caregiver, different all the dynamics changes. So we need to be sensitive about those issues, and accordingly, we need to address the psychosocial and spiritual need of the patient. And there can be depression, hopelessness, because the ailing parents who themselves are HIV positive, and probably some of them are in palliative care, so they may face depression, hopelessness regarding the care of their child if they die before them. And we need to take care of their depression with or without medication. And we need to counsel them in a proper way. This needs an interdisciplinary team, including doctors, social workers, psychotherapists, counselors, psychiatrists, and all of them are to be trained to provide counseling to address mental health issues. They may help them in dealing with the emotional effect of their illness, as well as the social environment in which they function. Now, home-based care, symptom and pain management, clinical or hospital referral for routine visit and acute care. So whoever is providing the outreach service, they need to be trained, and they should care about the child, these new symptoms. And based on that newer symptoms, the patient might need a referral to the nearest hospital or to the ART center. Now, treatment support for adherence and side effect management is equally important, because just suppose the patient's ART is not working, there is no other therapeutic options left to take care of the patient, whereby we can provide curative treatment. But then the patient is suffering from, say, esophageal candidiasis, and there is severe rhodinophagia, the patient cannot swallow. So if the patient is not adhering to the antifungal therapy for the esophageal candidiasis, then also the sufferings will be more. So we need to take care of the adherence of medicines, and we should provide proper adherence support to the CLHIV and their caretaker. The nutritional support, emotional support, spiritual support, we can link with the different religious organizations as per their belief systems. And then social service in the form of income generation, child support, and food support in case their HIV positive parents die. Then future planning for child, for family, preparing family, and identifying guardian for the child. All these things should be taken care of whenever we are addressing a CLHIV. And end of care life, that includes pain management, funeral, grieving support for the family. So the caregiver, to provide all these things, the caregiver need to know the basics of HIV or AIDS, personal and environmental hygiene, prevention of infection and injuries to themselves and to others, and management of infections at home, necessary information on essential nutritional needs and additional energy requirements, how to provide that additional energy, and information about medicines to be taken by the patient, possible side effects, and whom to call in case of emergency or whenever necessary. Now, it is very, very important that this caregiver, they also suffer from lots of anxiety, and they can have trouble sleeping. So caregiver should be in touch with the ART center to get advice on the suspected side. So I was talking about the caregivers. Now it is basically for the CLHIV. Now, since I started caregiver, let me complete. So there can be fatigue also. There can be guilt also on the part of the caregivers. So we need to address them. We should advise them to take care of themselves, not only in addition to the child, and they should also take adequate food and sleep adequately, so that they become capable of taking care of the CLHIV in a better way. And we can also include more number of family members to provide support to the primary caregiver. Now, the symptomatic management of the CLHIV at home can be in the form of what to do whenever there is cough or fever or hiccups, weight loss, nausea, vomiting, mouth ulcer, and pain on swallowing, or say for dry mouth, constipation, and incontinence, etc. Can be told to the patient what are the things that they can do. They should be able to elevate anxiety and trouble sleeping. The caregiver should be in touch with the ART center to seek for advice on the suspected side effect of any drugs, and they can only do when they are told of the possible side effects of a particular drug. The interventions to have effective home-based care for the palliation of the CLHIV at home, we need to have sterile gauze pads, around 20, then 1, 2 or 3 inch gauze rolls, 2 each, clean cotton, 1 small package, soft soap 1 bar, scissor 1 pair, calamine lotion, bleaching powder for providing sterile environment, and petroleum jelly or Vaseline 1 jar, gentian violet crystals or solution, potassium permanganate crystals, betadine ointment, rubber gloves or plastic bags, towels or clean cotton cloth. Then challenges faced by caregiver. Stress in the caregiver, as I already discussed it, is very, very important to acknowledge, and also need to provide them counseling for their for the elevation of anxiety, irritability, anger, guilt, if any, and we need to make them motivated to take care of their own self in addition to the children, and we can engage more number of family members if available towards the care of the dying CLHIV. And thank you. That's it. So over to Swetaji.
Thank you so much, sir. So we have one question in the chat box. If a patient stable on ART with best adherence, can there be a situation where palliative care will be needed at any point of time from HIV infection point of view?
Yeah, it's a very good.
What is the lifespan of versus non-HIV person?
Definitely it is shorter, and more so in the case of CLHIV, because the diagnosis of CLHIV is quite delayed. We know the algorithm for early infant diagnosis, so it also needs some time, and they are exposed to different kinds of antiretroviral medications while in utero, if the mother was put on antiretroviral therapy. And because of all these factors, finding a proper and the non-availability of child-friendly formulations of antiretroviral medicines, CLHIV tend to fail those antiretroviral medicine quite early, and their lifespan is definitely less than the HIV negative CLHIV. And for PLHIV also, it is a bit less than the HIV negative one. And the primary question that was asked, that if the patient is responding to ART adequately, still the patient can go into palliative care. On the HIV ground, no. But for different other reasons, say for example, the patient has developed some malignancy, then also he can go into, we might provide him with the palliative care. Say advanced HIV, advanced malignancy, disseminated one. So we know, say for example, the patient is suffering from hepatocellular carcinoma, advanced stage. So we know how much he is going to live. Even if the antiretroviral medicine is working nicely, the patient will die quite early. And we also need to provide this palliation in terms of for the hepatocellular carcinoma. And we need to continue antiretroviral as long as the patient survives, and also other preventive therapies as per the guideline.
Dr. De, I am Dr. Tripathi. Good afternoon to you.
Sir. Tripathi, sir, please continue.
Sir, my question is for adult PLHIVs. Actually, what the literature says about their lifespan, if they are continuing very fine with ART and adherence is very good. What the literature says, how much it is different from the person who is not HIV infection?
Exactly, I cannot say, but it is a bit less than the HIV negative. It is not full one, because you know the nature of the disease. Because of HIV, they produce inherently different types of mutants, isn't it? So naturally, one day they are going to develop resistance to the antiretroviral therapy. So if the patient has to survive, say 100 years, he may not be able to survive with the existing antiretroviral medicines that are there with us as of now.
Because this is a question many times patients ask also, particularly at the pre-ART stage when they come. Some people are very anxious and they ask this question.
we need to address the, well, yeah, it is very, very relevant one for that PLHIV. And we also need to tell them in a proper way that, yes, without medication, see, you are not going to survive for more than, say, 3-4 years. Okay. But with medication, you will almost live a normal life. That much we can say. We are not lying. We are saying the truth, but in a positive way, so that the patient develop trust on the treating physician, ART center, and the antiretroviral therapy itself, so that its adherence become adequate. Now, if we cannot say the positive word, then the patient may not be motivated to take the medicine properly, in which case the patient will die much earlier, isn't it? That is what we should do in a ART center.
Right. Thank you.
Okay, thank you.
Thank you so much, sir. Any more questions from the participants? You can unmute or you can type your question in the chat box. Sir, I don't think there are any more questions. Can we quickly run the feedback form, please? Thank you. The feedback form is now visible on your screen. You are requested to scroll through all the 4 questions and answer them. Requesting all the participants to please take the feedback poll. Kiran sir, we can end the feedback poll now. Rajeeb sir, thank you so much for facilitating most of the sessions for the East region. We are completing the series on the national guidelines for HIV care and treatment, and we'll be starting the routine topics from next month onwards. Thank you to all the participants for patient listening and participating in the sessions. Thank you. We'll conclude this session now.